wasn't born Italian, but I talk a lot with my hands too, so.
Are you recording the whole thing? Oh.
It's good to be back. What you need, Steve? Say what? Oh, Steve said to remind you there's drinks in the back. Okay? If anybody needs a bathroom break, I'm not going to take offense. Get up and go to the bathroom, come back, or whatever. Okay? So this is me. I've made the slides plain vanilla, as you can tell. There's no fancy pictures. There's not a lot of words. There's not a lot of stuff, so it's going to make them small slides. The reason I did that was so that you can get the slides if you want. You can get them from me. You can email me. There's my name's on the list of the board of directors over there on the page that Steve's made. I've got a USB, so you can get it if you've got anything that you can load the USB onto. I'm going to give them to Steve, so they will be available if you want them, because there's a lot of material. I haven't been here in about 5 years because there's been a lot of things going on in my family, some of which I'll tell you over the next lecture or so. I'm an emergency doc. Okay. I'm not a rehab specialist. I'm not a psychiatrist. I don't do psychiatric drugs, so I can't advise you on those. I'm not a neurologist. I fell into this because of an interest in electrical injuries, because of an injury to a friend of a relative of a friend of a whatever, before I even started medical school. Okay? And I knew nothing about it, but by the time I was a senior resident in emergency medicine, you're required to give a lecture. So I decided not to just do it on burns, but to do it on electrical injuries. And at the end of the lecture, somebody held up their hand and said, well, what happens with lightning? Is it the same? Oh, I don't know. So I went to the books. There were no textbooks in emergency medicine back there. That was in the late 70s. There was nothing in the books about lightning. Okay. So I pulled all of the cases that I could find. There was this one guy had one case, this guy had a couple cases, another guy had a case. But nowhere did it tell me as an emergency doc what I could tell a family if their son came in hit by lightning into the emergency department. I didn't know if he was going to live, or if he was going to die, or if he was going to have permanent problems, or what it could be, or anything else. So I coded a bunch of stuff, everything I could from these injuries. And that summer while I was working with the paramedics in Cincinnati, we had 7 cases, all in one summer, people injured, okay, 1 killed. So I coded all of them too. And at my first job in Louisville, I talked somebody into running the statistics through a computer. Now you can do more statistics on your cell phone than we could do back then with a room full of computers, you know. And we got some very simple correlations. We got, you are more likely to die if this happened. You are more likely to have this if that happened. Just very simple kinds of things, but they still hold up, okay? So basically, and then at some point, Steve called me and said, I remember the phone call too, he said, you're Dr. Cooper, right? Yeah. And you do some stuff with lightning. You do lightning, right? I said, yeah. He says, what do you know about PTSD and lightning? And I must have sounded really stupid because I said, I thought PTSD just happened to Vietnam vets. Because that's the only thing that was talked about at the time in the late 80s, okay? Mid-80s, when this started. Okay. But I came to the first meeting. I met Cal and Rose there, and the other 10 or 12, you know, some of them were old, hardened farmers from Montana that had driven clear across country to get there. Others were linemen that had been injured. There were people from all over the country. And we've been working on this ever since, haven't we, Steve? And Joyce, and Stacy, and many of the rest of your family. Okay. We're all volunteers. We're all volunteers. You guys didn't volunteer for your injuries, but we volunteered to be here to help. As an emergency doc and as a professional, I've been on many boards of directors, but I've never been on the board of directors of a support group. So I had to learn a lot from that too. And I decided what my purpose in being on the board of directors was to help the organization grow and become independent. Not to tell us what to do, not to tell it what to publish or what books to do or anything else like that, but to help it grow and nurture it just as a mother would a child. And so we helped it grow from infancy up to where it started walking. We incorporated the board so people who got upset with us because of their anger management problems from their injury couldn't sue the individuals on the board who were volunteers. We started raising some monies. The monies were specifically set aside, not for Steve and Joyce, not for the organization, but to help people who wouldn't be able to come to the organization otherwise. That money is set aside in a different fund that Steve and Joyce do not have access to. In fact, they still pay for their hotel room. Did you know that? It was years before the board of directors knew that they were paying for all the phone bills from getting called 24 hours a day with lightning. They were paying it out of their pocket. Okay? So Steve and Joyce have volunteered and spent their lives doing this for people. So, yes. So what I'm going to tell you is not anything that I've learned in school or formally or anything like that. It's what I've learned from you guys, what I've learned from reading, what I've learned from other brain-injured people, and frankly, what I've learned from personal experience. I have to tell you that I really appreciate what many of you have gone through, both from the survivor standpoint and from the support person standpoint, for two reasons. Well, first of all, my daughter, who was a beautiful 19-year-old young lady that we adopted from Honduras when she was a year old. We started our family late, so I still got 2 teenagers in the house at my age. She's an aggressive soccer player. She lettered in football when she was a junior in high school, too, boys football. Well, in February of 2009, she had a head injury as a goalie, fell down, hit the back of her head on the support posts in the goal, and then got up and played 3 more games, not telling anybody that she'd been injured, because she didn't really know. She didn't guess out. We do. Every time she dived for a ball, she re-injured. She turned what would have been probably a reasonably minor concussion, maybe out of school, out of contact sports for 7 to 10 days, into a major injury to where she was unable to go to school for 3 weeks because of the noise, the light, all that kind of stuff. Word-finding problems, couldn't complete a sentence. She read aloud her English or Spanish, which she's fluent in. She could read it aloud, but she couldn't comprehend it while she was reading. Okay? Sounds familiar, doesn't it? Okay? She had to have physical. She had to have physical therapy twice a week to learn how to walk again because she couldn't walk with her eyes closed. She couldn't walk sideways with her eyes open. She couldn't walk backwards with her eyes open. It was months before she could climb stairs. So I have a real good appreciation for what many of you are going through and have gone through. Okay? She ended up having to take pass-fail that spring term. She's an honors and an AP student. And eventually she got, because she couldn't do either her sports where she could take her anger out on the field, which she was always the enforcer on the team, on the girls' team. And she no longer could do her academic work. So she didn't have anything to give her self-esteem. She got into self-harm, suicide, stuff like that. Praise God, we found some help. She was away from home for 16 months in therapy. Praise God, we had the money to be able to cash in some of our IRAs and things like that and pay for her. She's back home now. She seems to be good. Pray for us. One of the things I also learned to help her that may help you is that our son, I'd still say he's a teenager because he's got a teenage mentality. He's 22, but he's got a significant learning disability. Turns out it's a genetic disability, which we didn't know until he was a teenager. But, you know, as a parent and as caretakers, you've had to become an expert in this, haven't you? It's sure not something planned on, was it? Well, I didn't plan on becoming an expert in a learning disability or the kind of head injuries and things like that that my daughter needed help for, or all that kind of stuff either. Turns out that some of the stuff that we use for the learning disability, we could use for Carly, our daughter, okay? So that when she was reading, she no longer could read, but she could use the Learning Ally. It used to be Reading for the Blind and Dyslexic. Okay? Tune into Learning Ally. It's got just about every textbook you want, including my son's specialized early childhood teacher's education books and all kinds of other stuff on tape, so it could read to her on the headphones while she was looking at the book, annotating for school. There's Kurzweil that he's used, Kurzweil. Kurzweil takes things from words to reading. It will read the text to you if you can input it into the Kurzweil. Dragon, naturally speaking, will take your words and put it in your verbal stuff, takes words to writing. Okay? So there's a lot of text, kinds of things like that that you can use. Okay, anyway. Sorry for the long introduction. Okay. So I'm going to be talking from 30 years of experience, both professional and personal, and that's where I'm coming from. I retired from patient care 4 years ago, and thank God I did, so that I could be around for my daughter and the kinds of stuff that she's been through. I don't review patient files anymore. I don't see patients. I don't even have any place to see patients anymore. And it's not good medicine to give advice over email. I'll have to correspond with some of you, but I can't give medical advice over email. Okay. But I can help in a lot of other ways. Okay. The people who have been here before know that I don't function as a doctor here. I function as somebody who listens, somebody, if I can answer some of the questions, I certainly will. But Cal used, I think it was you, that would tease me about, you know, the first time you came here, every time we ask you a question, you'd say, I don't know, I don't know, I don't know. About 10 years ago, he says, you don't say I don't know as much as you used to, you still say a lot. So, okay, so just, okay, so with electrical versus lightning injury, okay, you know that both have brain injury. Both can have chronic pain problems as well. With the high voltage electrical injuries, there may be amputations and major scars as well. Not likely to have that with lightning. You might have some, you know, marks and things like that with lightning, but you don't have major scars. You don't have a prosthesis on your hand and stuff like that. So what we're going to talk about is the things that are common to both of these: brain injury and chronic pain. Okay? The chronic pain lecture, if I try to give both of these at the same time, it's too much material. So Steve was kind enough to give me some time on Saturday as well, and we're going to talk about pain then. We're going to talk about how does electricity and lightning cause pain? Why do you have it? Why are you on several pain medications instead of just one or two that would work for you? What can you learn to do about your own pain management so that you can be a participant in that? Many of you have probably already learned that if you've had the injury for a while. So how does brain injury occur? First of all, the brain substance is really like Jell-O in consistency. Okay? You know that if you take a bowl full of Jell-O and kind of gently shake it a little bit, you get little micro tears in it? Well, think about what happens when you get thrown by lightning, thrown off of a pole because of the electrical injury, or jerked because of the big muscle spasm that happens with it. That can cause brain injury. Okay? Even if the electricity doesn't go through the brain, we consistently see the same or similar types of brain injuries from electricity and lightning. Now, when motor and sensory areas are affected, like with a regular stroke, like an older person would have, okay, those are not as nearly as often affected by lightning and electrical injuries. as by stroke and other kinds of things. However, what you all know is that the executive function areas are the ones that are affected. The decision-making, the adding, the subtracting, the organizing, how to get a dinner on the table, dispatching, running an office, doing teaching in a classroom. Many of the things that you've done as part of your professions or as part of your personal life, you can't do anymore because the executive function got wiped out. That's what electrical and lighting does. Okay. So, this quote, Nick Simkin, who is an attorney who's dead now, who was one of the mentors for this organization, came up with this at one of his lectures, and I've used it ever since. This is minor brain injury. You all are classified as minor brain injury because you're walking around, talking, and feeding yourself and things like that. So that's medically a minor injury. But minor head injury is when patients have difficulty in all areas that require them to analyze more items than they can handle at the same time. You don't have to copy this down because these are on slides. You can get them. Okay? They present as slow because it takes longer. Just as you were saying, it takes longer for the information, for the red light or the green light to get to your foot. It takes longer for smaller than normal chunks that they were used to handling to be processed. They're distractible because they can no longer filter out all of the other stuff that's coming in at them. Okay? They're forgetful because when they're concentrating on point A and their spouse comes in and says, "Hey, did you take the garbage out?" It doesn't process, okay? Because they're working on point A, not on whatever they said, okay? They present as inattentive because the amount of information that they give exceeds it's sort of like filling up a bucket, and once you get full, everything else just sort of falls out, right? Any of you get that feeling that you're just overwhelmed and you can't handle that? That's the way I felt Wednesday night, frankly. Okay. And one of the reasons I retired is that when I started taking care of my parents, and they're both gone now, I found out what kind of genes I have for brains. They start off real strong. They go down the hill real quick, okay? So I retired a little early, first of all, before the Illinois pension system went completely bankrupt, so I'm one of those evil Illinois pensioners. Secondly, because I wanted to remember some of the things with my kids in my retirement and my family before I fall off the end of the cliff, okay? So my brain doesn't recover all of the things as well as it used to in the past either. The immediate problems that you all know about from the brain injury: nausea, the GI problems, the feeling hungry but you can't tolerate much, and just, that feeling. The headaches, just intractable headaches. Once you finally start getting a little bit of control of the headaches, then every time you do a little bit more than maybe you had the capacity to do that day, headaches come back again, right? My daughter used to get headaches whenever she tried to climb stairs. You have problems with the word finding, with completing a sentence, with completing a conversation. You start something and then you can't say one of those prayers in church anymore where you're supposed to spout something out, like everybody else does and like you used to be able to do. Okay? Word substitution problems, difficulty reading or understanding new material, difficulty with noise, lights, and crowds, the dizziness, so trouble climbing stairs, other kinds of coordination kinds of things. Well, in the initial stages, there's often denial that it happens. Not always, but there's often denial. Nothing happened to me. I'm okay. Yeah, I had aches and pains for a couple days, but I'm okay. One of the problems is that, I've been reading and working with brain injury for 20 or 30 years. I can probably, if something happens to me, I can probably explain it. But you guys are not experts in brain injury. So it's difficult to even figure out for yourself what's happening, much less try to explain it to anybody else and tell them what you might need. And your family's trying to figure out where it comes from. And if it's a teenager that was injured, they're trying to figure out if it's just regular teenager craziness or whether it's something else. It's part of the injury. Okay. On top of that, then there's the confusion, the irritability, which often drives your caretakers away. Okay. The embarrassment, because you can't figure out why people are treating you that way, or why you ended up in the middle of Chicago at 3 a.m., or things like that, okay? And then comes the decreased self-esteem, the depression, the despair, the self-isolation, and frequently thoughts of suicide. Frequently thoughts that maybe it's not worth going on anymore. With the longer-term problems, you have problems with the short-term memory versus working memory. Working memory is if you were a plumber looking at the blueprints in the morning and then knowing the work you had to do the rest of the day without really having to go back to the blueprints very often. Okay? That's what working memory is. So it's sort of like RAM on a computer would be. That's where a major part of the injury is. Also in processing new information. Attentional problems, so attention deficit. The irritability, the distractibility, that kind of stuff again. The sleep difficulties, initially sleeping too much, and then getting to where you have trouble sleeping at all, or sleeping for more than 2, 3, 4 hours. Inability to return to the prior kind of work that we did. One of the things that I've gone over with patients that we've seen in the electrical trauma program in Chicago, and Norm was there, go over is the stages of loss or stages of grieving. You can look up Elizabeth Kubler-Ross. She's done a lot of writing on this. Excellent, really pioneering physician. Well, the first is denial, like we were talking about already. Then comes anger. Many of you are probably angry here today. Okay. Well, you may show some anger. Why don't you guys get doctors to come take care of this? Why isn't somebody doing research in this? No? All kinds of stuff like that. Okay. We sort of understand that. It's still hard to swallow, but we try to be patient when that comes at us. Right, Steve? So, and then there's the bargaining. If I could just find the right doctor who would give me the right pill or the right exercise or the right whatever, I'd be all better. Doesn't work that way. Most of us can see the end of, if we stubbed our toe or we burned our finger, we sort of know how long that takes to get better, right? Okay. And the problem with electrical and lightning injury is if it doesn't get better in 2, 3, 4, 5 months, you start thinking, is this ever going to get better? Am I going to have this the rest of my life? Oh my God, how am I going to be able to do that? And the depression gets in there. Okay. If you have good caretakers, people who understand you, time to learn about the injury yourself or your caretakers do, things like that, eventually, hopefully, you get to some level of acceptance. You get to the point where you say, yeah, this is a major problem. No question, it's a problem. But you know, I'm going to set it up on the shelf here, and I'm going to go on with my life. I know it's there. I know it's there. But I'm going to go on with my life and enjoy it to the best that I can. Okay, so let's talk about recovery. We used to be taught that brain injury is permanent. The brain doesn't heal. I was sure taught that. Well, now we have some better research tools to be able to measure the response to therapies, neuropsychological testing, better imaging, functional MRIs, not plain garden variety MRIs that they do on your knee to see if you need cartilage, but functional MRIs that measure blood flow, okay? PET scans, things like that. We know that we can retrain parts of the brain. Now the neuropsych things and a lot of the imaging, these are research tools. These are, let's try this therapy on a group of people and see if it's effective. See if the timing is effective, or see if the way we do it is effective. And then we'll measure it with the scans to see if that changed the area of the brain or the response of the brain or whatever. That doesn't mean you all should go out and get it, okay? So those are research tools to measure the therapy. So now let's talk about the therapies. One of the books that I reviewed for this talk, because Steve asked me to talk on rehabilitation, brain rehab, was Neuroplasticity and Rehabilitation by Sarah Raskin. I would not recommend that you go out and buy this. This is an incredibly dense book. But if you've got rehab people that you're working with, particularly the brain rehab, cognitive rehab, thought processing, executive function rehab people, this is a really wonderful book, and it's not expensive. It's only about $50, which is incredibly cheap for another book. And you can get it from Amazon. 2011. So they may want to read it, okay? So why are we taking lessons from brain injury, from Alzheimer's, from other kinds of research that's been done, instead of taking it from people, from research that's been done on lightning and electrical patients, right? Why do we have research on those? Well, let me tell you, research requires funding. To have funding, it requires a government priority, because you're talking about funding by NIH, the Centers for Disease Control, which do a little bit of trauma stuff, but otherwise you guys don't fit there either, or other government agencies. Okay? Those government agencies go where the volume of injuries, the lobbying, and the power is. But guess what? That's cancer, heart disease, HIV, and now bioterrorism. For the last 3 years, because of the prevention that we've done, there have been less than 30 deaths in the entire U.S. from lightning. Less than 30. And if you say 10 times more people were injured, that's less than 300 injured. More kids die every day, every year, from falling downstairs in those stupid little walkers than die from lightning. I'm sorry to tell you that, but this is an orphan disease. There's not going to be research in this area. There's good news, though, that we're going to cover about why there's hope. The motor and sensory areas of the brain are easier to rehab, but these aren't the ones that are injured as often in electrical and lightning. Motor sensory functions are the basic functions that everyone needs. Walking, talking, feeding themselves, tying your shoes, getting dressed, okay? Usually these skills are easily transferred from the physical therapy that you do in the hospital or that you do 2 or 3 times a week to your real life skills, right, that are necessary, okay? It's often repetitive kinds of things and motions, and then you can do it with strengthening exercises and keep practicing the same thing until you get a new pathway put together in your brain. Turns out that that's exactly what does happen, is parts of the brain start growing in the motor and sensory areas. They don't grow, but they become more turned on to do these functions. And that can be measured with some of those research scan tools I was talking about, okay? The way they measure it is by measuring blood flow to the area. When the area is active because it's trying to tell you how to move that arm, well, that's the part of the brain that lights up on the functional MRI that's finding oxygenated blood. Okay? And in fact, we do see larger areas in the motor and sensory areas from that kind of rehab. The executive function is not so easy because with the executive function, it's not the same repetitive thing. Executive function means you have to be able to look at a problem and go, and what are the pieces I need to do that? How am I going to figure that out? Where could I get in trouble? And often they're more complex tasks, and it's a new thing that you're facing frequently. So executive function is much more difficult to figure out how to give therapy for because it involves planning, forming the concept, mental flexibility, insight into what the pieces are, higher level attention skills, it's working memory to work on it, behavioral regulation where you're getting rid of things that don't need to be part of this task and concentrating on that. Social skills. You don't go to the grocery store without having put your clothes on and without having put appropriate clothes on and things like that. You know, gotta think about those things before you go do that executive function. okay? And it may require switching between tasks. And lots of times with brain injury, you get stuck on one task and you just keep doing it, and doing it, and doing it, and doing it.
Yes,
So executive function is not so easy to train. Plus, it has to, whatever we're training has to be relevant to the individual. It has to be helping the person who's in the mine and rescuing people, because I know you did a lot of rescue stuff, okay? You were in charge of so many things for the mine assignment. I remember our talks. Or you have to be able to organize the meal that evening for your family, or to be able to organize your lesson plan for the kids the next day, or whatever it is that's part of your profession. Okay? It involves training connections in the brain, where the frontal lobe comes up with all this executive function and then tells this arm to do this and that foot to do that, and until you get it all organized and make decisions. Okay? One of the problems too is when you do too much training in executive function, it becomes a habit instead of a way of looking at new projects and making decisions. So you can actually overtrain in it and make it worse. Part of the way of countering that is for the therapist to do training with increasing difficulty, increasing diversity, increasing complexity of the tasks. That takes a really skill.
I didn't follow that, where you said it might be too much and be harmful. I don't understand.
Okay. Let's see if I can figure out another way to say that. If you're teaching someone to get on a bus and figure out where they're going, and you keep teaching them to go to the 3 places that they need to go in their life, you do it too much, it becomes a habit, and then that's all they focus on. You haven't taught them how to get on the bus or how to look at the map and figure out a new place that they're going to go if they're going to go to a museum of science and industry with their kids for the afternoon.
All right.
Okay? So you get stuck in a rut.
Okay.
Okay? Does that make sense?
Yeah.
Okay. Okay, executive function therapies also have to include changing the environment someone's in. I bet many of you have done some of these already. You have to get around problems that might be distractions, okay? For instance, when my daughter was trying to read her texts for her AP English that she was taking that spring after the injury, she would get in the corner of the kitchen with the computer. The computer was off except for reading her the book. She'd have her earphones, so she cut out her visual distractions, she cut out her auditory distractions except for what was coming through on the phone, earphones, as she was looking at the book and including the book. So she couldn't hear me cooking, she couldn't hear her brother watching TV, she couldn't, So you cut out some of the distractions if you can. Organize the space. Put labels everywhere. I think Rose has done this in her kitchen, if I'm right. You've got labels everywhere for where everything's organized, okay? Maybe you post the operating instructions next to the areas, the laundry, the microwave, that kind of stuff, okay? You teach task-specific routines, but increase the complexity with it. So you're teaching not just getting on the bus and figuring out how to get off, but figuring out new places that they may want to go, new puzzles, okay? You have to avoid emotional overload, because you do that, you really need to train from success, not from failures, okay? And that was one of the really good things I learned here for my son with his learning disability is that's what we've got to do to get him through some of the tests that he's got to do in order to be a certified teacher in Illinois. Build on successes. Okay. Goal management training often involves self-talk. Stop. Say, what am I doing? What is the project I'm going to do? What does the task involve? What are the pieces? Break down, like the sausage, one slice at a time. Okay? Break down the pieces. What steps? How do I approach each of these steps? How do I solve each of the steps? And then periodically check and see, am I doing what I plan to do, or did I get distracted? Okay? You need to give yourself enough time. Somebody said it took 3 times as much time to do stuff. Recognize the real-world time pressures. Okay, prevent the time pressures by having a plan. Have an emergency plan if things start getting out of control. Monitor your performance. Again, avoid emotional overload and too high expectations. Know when to stop. How many of you have gotten into this situation where you go, boy, I'm having a really good day. I think I can do a little bit more. What happens?
You crash.
You're correct. You wipe out for the next 3 days, right? You can't get out of bed. Okay? So, learn your limits. Learn to be humble, or whatever. Okay? Learn your limits. Learn when to stop, so you've still got a little bit of reserve left, so that you'll be able to get out of bed the next day. And none of us are Superman anymore. Okay, part of this may also involve self-talk in a social situation. I wish somebody had taught me this before I went to college, you know. Somebody should have told me how to do this before I went to parties, because I'm not very good at parties. Okay? When you walk into a room, or when you're going into a situation, whether it's going to see the Social Security people, going to see your doctor, going to church, whatever, think about who's probably going to be there that you're going to talk to. What are the things you need to say to accomplish the stuff that you want to get done? Okay? Where would you look for help if something doesn't work quite right? I went into the doctor's office the other day, and instead of talking to the receptionist and saying, hey, I'm here with my kids, or whatever, I had to sign into the computer. And the doggone computer wouldn't, I had to sit here and poke a thing, and it wouldn't do what I wanted it to do. And then I found out there was a pen laying down there that I was supposed to do with the pen. Okay, well, who do I ask for help when it doesn't work right? Okay. You can also rehearse this kind of thing. This is the kind of things that we were taught to do with our kids. When our kids had a fight the day before, and we talk about it, we talk about how they're going to approach it the next day, or how they're going to talk to their teacher, or whatever. You sit there and you help them rehearse it. Rehearse the things they're going to say, okay? Rehearse how they're going to do it. So that it decreases the pressure because they're more sure of what's going on. Same thing happens to you. There's 3 levels of rehearsal. The first several times you do this, and you can do this with your spouse if you're the caretaker, you can go through the verbal, the what do you do, how do you do it, yada, 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 all that kind of stuff. The next time, the person can start saying it to themselves. Now let's see what pieces that, how am I going to do that? Okay. And then it can get to where it's whispering, and then it can get to be where it's just thinking, these are the things I need to do, and this is how I'm going to organize it. Okay. So it's a training process. There are several unknowns in therapy research. Okay. A lot is still unknown, and that's one of those things the book taught me. Is how do you train differently for executive function versus the motor sensory? We've been doing motor sensory for a long time because of stroke patients. But how do we really teach the executive function? Depends on where the size and the location of the injury are, if it's a specific kind of injury, like a tumor or something like that. So therapy may be different because of that as well. Depending on whether it's a diffuse injury like you all have, or a focal injury. How about the intensity of the therapy? What age, when should you start it? How often, how many times a week should it be? How do you advance into the different complexities? Is the timing different for different patients and different injuries? Is it therapy different for different ages of patients? We don't know these things. Thank goodness a lot of this stuff is coming about. The good news for electrical and lightning survivors is, in the past we used to say, well, you need to find somebody who does lightning for electrical patients. You're not going to find that. You all know that now, right? Okay, you're not going to find that. But you can find people who know brain injury. And one of the things I think I've come up with after doing this for 30 years is, first of all, the brain injury stuff that works for other people most likely can be adapted to you. There may be more difference between each of you sitting next to each other than there is between you and some of the brain injured people that are in rehab down the street from you. Okay? So you can take the pieces that seem to work, and it doesn't have to be lightning electrical. How many of you have gone into a doctor's office and said, I got hit by lightning, and they go, oh, I don't know anything about that. You better go to some specialist. Which means get out of my office, right?
Yep.
Okay? So tell them you have a brain injury. You don't have to tell them it was lightning or electrical for probably another visit or two maybe, okay? So, because it makes you sound like a weirdo. Yeah. Maybe that's the wrong advice, I don't know, but I think you've all learned some lessons walking around and telling people you're injured by lightning. The good news for all of us electrical and lightning injured people is that there's more interest and need now for brain rehab than there ever has been before, okay? All the stuff that's out in the news about sports concussions and stuff like that, oh my goodness, okay? It's not just the professionals, it's all the way down through all the state laws for the high schoolers and the football players and the high school and stuff like that, and how long they have to be taken off the field if they get a stinger or if they get a little confusion or whatever. So it's really out there. Plus we've got all these military brain injuries from the IEDs. There's a lot more recognition that rehabilitation is actually possible. You know, they used to go, you're hurt, out here, you know, can't do anything. It's actually possible now. It's not hopeless anymore. It's the expectations that we can actually do something are becoming the norm instead of the exception now. So there's more application to electrical and lightning survivors than ever before. The research is now on the young and healthy patients. There's more knowledge, there'll be more application, more flexibility, and I think there'll be a lot more recovery. I don't know how well it's going to work for those of you who have had injury 10 years ago, 30 years ago, whatever. Chances are you've already figured out your own therapy a lot by now, actually. And this is for Rose. Remember? Okay. I told this story, I think, it's actually a story that was told to me when I was an intern by an orthopedic surgeon. And I modified it, I think probably the first time I came to the electric shock meeting, and Norm's heard it too. You know, think about your life as being like a beautiful teacup, okay? Say your grandma had this teacup, and she loved it, and it was special to her, and she'd have her tea every morning. She died, and as you were going through her stuff, you found the teacup. You don't need it, maybe don't even drink tea. But it was special to her, so it's special to you. So you take it and you put it up on the shelf, and you just take it kind of for granted, and it's there, and you look at it every once in a while, and you know, you take it for granted, just like you probably took your life for granted before the injury. Well, it gets knocked down some day and falls down and breaks. And that's your injury. And you just can't, you don't want to throw it away, because it's still important to you. So you get the pieces together and you kind of glue it all back together as best you can, okay? It's not strong enough anymore to hold tea. But you can hold a plant. You can hold your change, your keys, a child's toys. It can still have a lot of functions. Even if it's not the way it used to be. Even if it's not the way you planned it was going to be. And that's the way your lives can be too. It may not be what you planned, but you can still have happy, productive, positive life with your family, your future. Thank you.